Good evening, friends. Welcome to this Tuesday evening critical care meetings and this online webinar program. This has been a phenomenon for the last couple of years. We bring you the topic of interest of that particular time. So tomorrow being the World Sepsis Day, that is 13th September, is celebrated or organized as a World Sepsis Day to create awareness in form of sepsis. Sepsis, a very severe form of infection, is been one of the leading cause of death across the world, not just in the countries where there are resource limited, but in countries like India, the number of deaths and the number of eventualities with this kind of deadly problem is multifold. And that too, the limitations of doctor-patient ratio, healthcare beds patient ratio, and many resource limitations makes this sepsis a more lethal cause. The definition and the identification of sepsis has been gone through multiple levels of changes from 1991 till date. The latest surviving sepsis guideline, which is released in 2021, has its own stand. From 2016, we had a new definition to come. So there has been ups and downs in the learning curve of sepsis. But our agenda today is to create a more deeper awareness related to the sepsis and to discuss about not just the antimicrobial or resource control, what are the things which has been tried, experimented, or even successfully done, or we are yet to prove them successful. We have Dr. Hareesh, who joined as a consultant in the Department of Critical Care Medicine, Yashoda Hospital, Hitec City. He graduated from Postgraduate Institute of Medical Science in PGH, Chandigarh, and did his DM from All India Institute of Jodhpur, and he joined us as a consultant in the critical care. So he will take us through, and the sepsis is silent killer. Beyond antimicrobial, what are the things we can do to save more lives? To moderate this session and share the wisdom, we have none other than Dr. Mnaimala Rao, whom I can think about that for this session to moderate and share her experience. She's on board. Ma'am, can you switch on your camera? Mnaimala ma'am.
Okay.
Yeah, so ma'am, switch on your camera. So we invite you on board, ma'am. Thank you for accepting our invitation.
Thank you.
I could not have thought any other alternative name to when we actually thought about getting experience sharing of this last 40 years of sepsis management. I thought you will be the right person who started the intensive care unit concept in the city of Hyderabad and groomed many students under you. So over to you, ma'am, to chair the session and invite Dr. Hareesh.
Thank you, Venkat. It's always nice to join all of you youngsters now, doing a lot of great service, particularly to sepsis and septic patients who come with multi-organ failure, and being in a corporate sector with a very high-end, critical care units, you are faced largely with patients who come late to us, and that is a great challenge. And now, without much ado, let us request invite Hareesh to take over and then talk about sepsis, what has happened over time, and how are we dealing with it, and what is the mortality rates and so on. Dr. Hareesh, please. Yeah. Consultant critical care in Yashoda Hospitals, and Hareesh.
Thank you, ma'am.
Now you have to share the screen.
Share your slides.
Yes, sir, I am sharing the screen.
Can make it full screen, Hareesh.
Yeah, I see.
Yes. Yes.
Sir, is my screen visible?
Yes.
Yeah.
Yeah. Good evening, everyone. I am Dr. Hareesh Ayyawar, consultant critical care medicine in Yashoda Hospital, Hitec City. And before jumping into the presentation, my sincere thanks to Venkat Kola sir for giving me this opportunity to present this topic. And also, it's my honor and privilege to present and discuss this topic in front of Mnaimala ma'am. Thank you, ma'am. So coming to the topic, so sepsis is defined as a life-threatening organ dysfunction. So that is mainly caused by the dysregulated host response to the infection. So if you see the epidemiology, like CDC, they reported in 2016, like there are almost 17 lakhs people got affected with sepsis in 2016. And the cost burden also, if you see here, it's very, very high, and the mortality was also very high according to the CDC report. And the same the burden of sepsis in India, if you see the global burden according to this study published in Chest Journal, so almost 50 million sepsis cases was there are almost in 2017 total 50 million people got affected with sepsis, and out of which almost 20% mortality they are reported. And this mortality was very, very high in lower and middle income countries. It was almost 85% compared to higher income countries. And in India in 2017, the reported cases were almost 11 million population got affected with sepsis, and out of which almost 3 million mortality was observed. So this is one study published from Kolkata, India. So the epidemiology of adult population sepsis in India, it is a single center study, 5 years experience. Almost in this year, almost in the 5 years, single center. So they have almost admitted around 5,000 people with sepsis, severe sepsis. And if you see the mortality also, it is almost more than 50%. So ICU mortality, hospital mortality, everything was more than 50%. And the most common predominant infection was respiratory tract infection, and which is gram-negative microbes, and the most commonly seen organism was Acinetobacter baumannii. And so to create the awareness, actually the research was started earlier in the 1990s. So after that, sepsis guidelines has progressed and evolved over a period of time. And recently they published sepsis guidelines 2021 recently. So they highlighted the importance of a 1 hour bundle. And whenever on presentation, the zero time, we should measure the lactates, and we should obtain the blood cultures and administer the broad spectrum antibiotics, and we should do rapid for the resuscitation, like for hypertension also, earlier initiation of the vasopressors to maintain the initial map of more than 65. These comes under the bundle. So also the source control is very, very important along with resuscitation. So they also highlighted the importance of timing of antibiotics. So when there is suspicion of sepsis with shock, so we should administer antibiotics within 1 hour of recognition of the shock. And when there is no shock, but the sepsis probability is very, very high, still we need to initiate antibiotics within 1 hour of recognition. If there is a doubt whether it is infectious or non-infectious causes, in that case, you can just frequently reassess, and you can administer within 3 hours. And if you and here, if you see the pathophysiology, it is mainly the dysregulated immune response. So the initial phase, there is a inflammation and the intense inflammatory response. Later, there is a transmission phase, and later patient landed up into the immunosuppressive state. So almost 10% of the mortal deaths were seen during initial intensive inflammatory response, and later almost 30% of the mortality was seen in the later part of the course, where the immunosuppression was very high, and because of the immunosuppression, there are so many secondary infections, and finally there is a very high mortality. So if you see the hyperimmune response, so in different conditions, like recently we had a COVID pandemic, so where the cytokine storm was very predominant. And if you see the levels of TNF, interleukins, and other cytokines, so sepsis and ARDS and COVID-19 with ARDS, there are very high rise in TNF and interleukin levels. So this is very important for today's discussion, where we targeted the newer therapies like beyond the antibiotics, like immunomodulation. So the reason being, it is very immune response syndrome. So our main focus of this topic is to address what are the different immunomodulation therapies, and what is the evidence of in sepsis. So there are so many immunomodulation therapies, and mainly highlighted important immunomodulation therapies such as activated protein C, steroids, statins, and plasmapheresis, IVIG, and some of the blood purification therapies and immunonutritions. So coming to the activated protein C, there are initially there are major trials like Provis and Enhance. They showed some mortality benefit with this activated protein C administration in septic shock patients. So they found almost more than 5% of the absolute risk reduction in these two trials. But later on, this was not reflected in the further trials. Like this is another major trial, like Provis shock trial, where they used activated proteins in adult patients with septic shock. So, but if you see the mortality at 28 days and 90 days, there was no difference. The p-value is more than 0.05. So they did not find any benefit with activated protein C. And coming to the steroids part, so how steroids are going to help in the patients of sepsis. So what are the theoretical benefits of steroids? If you see, steroids increases the number and sensitivity of the alpha and beta adrenergic receptors, that so that the response to the inotropes is very good when there is a increased sensitivity, and also decreases the release of adhesion molecules, and increases the anti-inflammatory cytokines and decreases the pro-inflammatory cytokines, and it inhibits the arachidonic acid, so that the inflammatory mediators production will be reduced, and also inhibit platelet activating factor, and prevent neutrophil aggregation, and it preventing DIC, and also inhibits the inducible form of nitric oxide, where nitric oxide is plays major role in vasodilation. So if you give steroids, that will be blocked by the steroids, and so there is no hypertension and vasodilation. That's what they mentioned. According to, this is based on theory. So if you see the steroid, the evidence for steroids, so steroids role was initiated. They started discovering the role of steroids in 1976. So the first major trial was performed in 2002. Annan trial followed by Carticus, and there are so many trials. They studied the role of steroids. So in the Annan trial, they studied the effect of treatment with low dose hydrocortisone and fludrocortisone on mortality in patients with septic shock. So they found that there was no They found that there was no significant effect of steroids on mortality in responders. Responders means here they did corticotropin test, so to assess the whether patient is adrenal insufficient or there is sufficient adrenal reserve. So in the responders there was no benefit, but in non-responders where there was a adrenal insufficiency. So low dose steroids do reduce 28-day mortality and vasopressor dependent time. And another trial called Corticus trial. So they investigated the role of hydrocortisone therapy for patients with septic shock. So here they gave 50 mg of hydrocortisone say every 6 hourly, then taper dose versus they compared with placebo. So they found that hydrocortisone did not improve survival or reversal of the shock in patient with septic shock, although reversal of shock was faster with hydrocortisone therapy. And another trial where adrenal trial, they investigated the role of again the steroids in septic shock patients, and they found that continuous infusion of hydrocortisone did not result in low there is no they found there was no low decrease in mortality, but steroid use led to more rapid resolution of the shock. And Hypress trial, this is like they have given the steroids earlier in case of in sepsis cases to prevent the shock, but they did not find any benefit to prevent the severe sepsis to shock progression. And Approaches trial, again also they compared the hydrocortisone and chlorcortisone compared with the placebo. So hydrocortisone and this combination, chlorcortisone combination, showed both a mortality and resolution to shock benefit. This is the positive trial. So finally, based on the previous trials and RCTs, Surveying Sepsis Guidelines 2021, they suggested using IV hydrocortisone, either infusion or 6 hourly boluses to when patient is in severe septic shock and ongoing requirement of the vasopressor therapy, you can initiate based on the guidelines. So another molecule for immunomodulation therapy was statins. So this has a immunomodulation property. Along with that, it is a antioxidant, and it modulates the apoptosis and cell proliferation, and also affects on the coagulation and it to prevent the DIC part. So, but all are negative trials. So almost every trial there was no benefit with statins. And later, there was another regimen called HAT therapy, so hydrocortisone, ascorbic acid, and thiamine. And there are so many trials: Victus trial, Vitamins trial, ACTS trial, Lovit trial, and multiple other trials also there. So, but they did not find any kind of benefit with this HAT therapy. So, Surveying Sepsis Guidelines was not suggested using IV vitamin C in patients with sepsis and septic shock. And another like therapeutic plasma exchange role in septic shock. So this is based on the guidelines where the guidelines, American Society for Apheresis guidelines, where they gave category 3 for sepsis with multi-organ failure. Category 3 means there was no established role for the use of therapeutic plasma exchange in patients with sepsis and multi-organ dysfunction. And coming to the blood purification, extracorporeal blood purification in patients of sepsis, there are different kind of mechanisms where the middle molecules, mainly the cytokines and the other inflammatory mediators, where these are middle or large molecules, these will be removed by two processes like convection and adsorption. So they used different modalities like CRRT with high volume hemofiltration, and they use different adsorption mechanisms where they use filters like cytosorb, oxyris, and torimixin. So cytosorb mainly adsorbs the pro and anti-inflammatory substances. So it absorbs mainly the cytokine part, but not the endotoxins. and other filter is polymyxin B hemoperfusion filter. This was also one of the filter where based on the absorption property, where this was endotoxins and endotoxins are mainly the part of cell gram-negative bacteria cell wall. So this was absorbed by the polymyxin B hemoperfusion. Coming to the evidence, cytosorb, there are some RCTs. They couldn't find any they did not find any kind of benefit with cytosorb. And polymyxin B, there are important trials like UFOS, Abdomix, and Euphrates. I will discuss with this. Initially, they used polymyxin B hemoperfusion with in abdominal septic shock. This is UFOS trial, and they found improved hemodynamics and organ dysfunction and reduced 28-day mortality. But latter part, this was not reflected in other studies like Abdomix trial. Same, they used polymyxin filter, but there was no improvement in organ function and hemodynamics, and there was actually increased mortality in the Abdomix trial. And Euphrates trial also, they use same filter, no benefit, and so many other RCTs also found no benefit with toremixin. And another filter is Oxyris filter. This filter contains 3 layers. One is heparin coating. The above layer is heparin coated, and for the middle one is layer absorbs mainly the endotoxins, and the lower one absorbs cytokines and other inflammatory products. So this was also this Oxyris absorbs both endotoxins and cytokines. If you see the difference, so cytosorb absorbs cytokines, toremixin absorbs endotoxins, and Oxyris absorbs both endotoxins and cytokines. And coming to the role of hemofiltration, where the convection is the predominant mechanism to remove the inflammatory mediators such as interleukin-6 and TNF-alpha. In this trial, actually, this is a systematic review and meta-analysis published in ISR and Hematology journal. So they could actually, this hemofiltration could eliminate inflammatory mediators in plasma effectively and shorten hospital stays and better stabilization of the hemodynamics. But there are so many limitations in these RCTs. And other modalities like blood purification and mortality in sepsis, meta-analysis of the different randomized trials. So different methods of blood purification such as hemoperfusion, plasma exchange, hemofiltration with hemoperfusion associated with lower mortality in patients with sepsis. These results were mainly influenced by the studies using polymyxin B hemoperfusion, especially from Japan based studies. And but the recommendation says that Surveying Sepsis Guidelines 2022, they suggest against using polymyxin B hemoperfusion because of the very low quality of evidence, and the RCTs are very poor with a lot of limitations. And immunoglobulin role also, there is no clear-cut evidence to use IVIG in sepsis. So they are also recommend against the guidelines against to the use of IVIG. And other immunonutrition, this is the using glutamine as a immunonutrition in patients with sepsis and septic shock. So this is the systematic review and meta-analysis published into the Critical Care Journal 2015, and they did not find any kind of hospital mortality benefit, and they did subgroup analysis where the trauma patients and burn patients were analyzed, and trauma patients there was no benefit, but in burns patients there are some benefit with enteral glutamine. So these are different other immunomodulators like granulocyte, monocyte, colony stimulating factors, and interferon, interleukins, and thymosin alpha. But there is no clear evidence to suggest these molecules in the sepsis and septic shock patients. And one more drug called Sepsivac, which is a Mycobacterium welchii. It is an immunomodulator which with a non-pathogenic property. So here this study was published In Journal of Critical Care, it is a randomized trial of Sepsivac in severe sepsis. So the use of they concluded that the use of Sepsivac in severe sepsis associated with significant reduction in mechanical ventilation, hospital length of stay, and ICU length of stay, and lower incidence of nosocomial infection and SOFA scores. But the sample size is very small, and there are a lot of limitations in this study. And again, one more study published in Chest also, they found good results with Sepsivac, but again, so it's small study and a single center study, and there is no much the number of patients are also less. So it was also not, there are a lot of limitations in this study. And another molecule called ulinastatin. Ulinastatin mainly, like this is one of the protease inhibitor. So what happens in the sepsis is like there are some serine proteases which are helpful in the which potentiate the inflammatory response. So these if you reduce those serine proteases, or if you block those serine proteases, we could find some benefits based on this property. The ulinastatin was studied, and they found some benefit, and based on some systematic review and meta-analysis of the randomized trial, they found some benefit. But again, these studies are not well planned studies, and these are single center and very there are a lot of limitations in the study, so it was also not proven clearly. And this ulinastatin showed some mortality benefit, as well as it reduced the Apache score and multi-organ dysfunction scores. To summarize, sepsis is most frequent reason for ICU admission with very high mortality. So early screening and rapid resuscitation helps to improve the outcomes. And immunomodulatory therapy still we don't have any clear-cut benefit or clear-cut role to use on a regular basis, but further research is definitely required for better outcomes with immunomodulation in sepsis, because sepsis is definitely the hyperinflammation type of response. So obviously this is going to help, but definitely we need further studies to prove this efficacy. Thank you.
Thank you, Hareesh, for that overview. You can actually stop sharing your screen. So, Mnaimala ma'am, can you switch on your camera? So that's a overview, and we have been still dealing the sepsis as one of the leading cause of deaths in many of our ICUs and all. And as he pointed out, a recent point care survey or a point of care study suggested that almost 11 million cases of sepsis in India in a particular year, and almost 3 million deaths, that is close to 30 lakhs. You can just imagine how many deaths happens to the sepsis. Probably this is second to those cardiac and neuro and cancer deaths happen. And this goes undiagnosed, and sometimes it even go unnoticed. If you see the public awareness aspect also, if somebody gets a chest pain and some hospital informs him that this patient probably may have a heart attack, the intensity of worrisome or the sensitiveness of that issue is taken very seriously, and families and the doctors take a optimal care so that the patient reaches to a center where there will be a appropriate care given. Same way, if you see a brain stroke or a IC bleed, we talk about time is neuron, and patient need to reach to a hospital so that now you can get a therapy to recanalize them. But we don't see the similar kind of sensitivity or similar kind of seriousness when in situations like sepsis, even though it is one of the leading cause of death. And there is another concern that over the last few decades, even though there are so many thousands of studies, so many thousands of therapies came across from the era of Madam to our era, we have still seeing a good percentage of our population, as Dr. Todi's trial study recently showed, we do see around 40 to 60% of deaths in the patient with septic shock. So this has been a very serious concern for all of us. So we felt on the occasion of World Sepsis Day, that's the 13th September, which has been designated to create awareness among the clinicians, among the regular public, and to probably make ourselves learn about it so that we can save few lives. To discuss this, we actually were fortunate and privileged to have Dr. Mnaimala ma'am, who is our former head of the department, Nizam's Institute of Medical Science, and was a HOD in the Somajigoda unit of Yashoda Hospitals, and was a part of this medical education and treating the sepsis patient probably over the last 4 to 5 decades. Ma'am, we have gone through a lot of confusion over the definition of sepsis. And yet I strongly believe that many of our clinicians also struggle to differentiate between what is a infection or what is a severe infection and what is now we are talking about a sepsis. Even in the scientific forum from the days of 1991, from SIRS criteria, and now we are talking about a organ dysfunction. Now we are also talking about a dysregulated immune response. Theoretically, this all looks very good on paper, saying something like dysregulated host response, getting an organ failure scoring. But practically, ma'am, when I talk to a clinician in a peripheral center, in a clinic, so to just identifying a dysregulated host response, to define it as a sepsis and differentiating it from an infection is always a challenge. We don't have any objective criteria to differentiate. It is a theoretical concept of saying a dysregulated host response. And what is the dysregulated host response? How do a peripheral clinician will pick up that? That still be a challenge. So there are many clinicians probably who will be watching our webinar. So what will be your take, ma'am? You have gone through all these definitions in your career. So what do you take from this day when we are just waiting a day of World Sepsis Day? What is your message, ma'am, on this?
Thank you, Venkat. I think it is not an easy topic to be discussed because it has been, sort of put into a sort of a mill, and from the beginning they have done so many things, but still we are still at the not at the bottom, but still we are groping in the darkness on some issues. But anyway, sepsis, as we have known, is something which is caused by an infection. That is understood. Now they are saying once the bacteria enters and causes sepsis, there is a dysregulation between the inflammation and immunity. So if any one of them during the time of its invasion, if there is hyperinflammation, you have a problem. And if there is, low immunity, there is a problem. So the hyperinflammation, which can occur because of the bacterial invasion, is in the early stages, which can be tackled. But most of the time, why we have a problem is sepsis is not a particular disease belonging to an organ. It is for the whole body, mind and soul, like that it is. So that is the reason, like in a stroke patient, now you have got excellent way. The moment that he comes, it is taken care. And if it is, from the door to the, PTCA, we are doing it in about just within an hour or two, or even within 4 hours, we can finish the whole thing. That is because it is only one organ, and we know what is the organ is going to cause. For the brain, either you have a difficulty in speaking, or not able to walk, or a giddiness, or a seizure, or unconsciousness. For the cardiac, you can have any other things which are related to the cardiac. We know that they are very simple and people understand that. But for sepsis, if there is even bacteria invaded, you may not have fever. Many times you may have fever, you may not have fever. And the fever, people will think for, it's just ordinary fever. Till it goes to a dysregulation, then only they will come. And that is the time if they can come, we can do something for them very quickly, because we can give the fluid, we can give the steroid if it is required, or we can give the noradrenaline and the vasopressin, whatever it is in a protocolized way, because most of our sepsis will be seen in EMD, emergency medicine, and sometimes in the wards. The less in our ICU, because they come to us only when they've exhausted all their whatever the paraphernalia for treating, then sometimes they should. So the physicians who are treating these cases should be told to send them early to the ICU, and even from the emergency, just to see what is the, I mean, they said Q so far, that also went. But what is the most important for EMD is to understand, is the patient stable? Is he awake? Is he having a respiratory distress? Or is he having any other, acute problem? So I'm tachycardia. If all four are present, and even if there is a fever, with the history, we can make out whether it is an infection or whether it is not. I mean, how the patient felt in the 1 or 2 days before, how it is. So history here is also very, very important, like any other place. Or any small area where it is infected, whether he had a small trauma, he didn't see it. So all these things are a little more difficult. That's why sometimes to put it across to people also is difficult. But if you can make them understand, if there is dysregulation of the immune system, or at least hyperinflammation, which can be seen as a tachycardia, fever, you can have a patient is a little bit not taking anything, not eating properly, or is a little somnolent. These things can put us to a little more towards that. So this is actually, we know that sepsis has become the #1 killer now. Even cancer and all, it is much less. Even your cardiac and strokes also have come down because they have been managed. But this is a major illness affecting all organs. If there is a hyperinflammation, every organ in the body is affected. Then a little later, the urine may come down. A little later, maybe your creatinine may go up. So all these are, so to exactly pinpoint and say these are the things. But I think a little bit understanding of these 4 things, like your,
Exactly,
blood
ma'am.
pressure, heart rate, and respiratory rate, and also your mental status, can give you to a certain extent going towards that.
So, ma'am, as you rightly pointed out, the agent, which we called either a virus, bacteria, protozoa, or what we've seen with COVID, and then a host, and then an environment. The 3 interactions, what we always called as in the studies of that, the 3 interactions creates a disease, and the host response also equally plays a role. As we see, many patients get dengue, many patients with COVID. Why one particular patients behave differently from others? Because of their host regulation or dysregulation of their immune response, as you rightly pointed out. But probably the challenge is, as you said, for a myocardium or for a neuron, you have a specific test, a specific sign, or a specific imaging technology where you can definitely say, okay, this is this, and probably this you need an intervention. Whereas sepsis being such a heterogeneous phenomenon, where, as you said, multiple organs are involved, patient can present in multiple ways, to identifying a fever leading to a dysregulated immune response or whatever hyperinflammation or immune paralysis. That's where many challenges came. So, ma'am, if you point out those clinical findings where you saw a drop in blood pressure, tachycardia, sensorium, if you see the recent even sepsis 3 guidelines, try to definitions, try to put across saying a Q SOFA. But post Q SOFA, which they said 3 organ dysfunctions in a quick clinical way without requiring any biochemical parameters or investigational parameters, sensorium dipping, systolic blood pressure dropping, or a tachypnea happening, can be an early sign that the patient is an organ failure, so need to require a higher monitoring or a more intense care in ICU.
Yes.
But the problem happened with that in the last 4 years, ma'am. The multiple literatures now suggesting that these may be a signs of a sicker patient. These may be a signs of indicating a higher mortality in them. But a good chunk of septic patients who are not landing to those situations may still get missed. So we are again talking about whether we use a QSOFA or the earlier scores like MEOS or something like the earlier warning scoring systems may be equally as effective as it. You have gone through those all SIRS to this QSOFA, ma'am. What do your experience? Harish, you have been gone. I think ma'am has gone into a hold. You have gone through this, ma'am. Are you able to hear me? Harish, you have gone through this both definition in the 2016 to 2023. We have seen QSOFA being projected as a pickup in out of ICU setups in a ward or in a out of hospital settings to pick up a sicker patients in sepsis. But
Yes,
later on, we realized that the sensitivity of this QSOFA is extremely poor. What is your
Yes.
take on it?
Yes, sir. Usually, whenever we get the cases in ICU, like if we follow the QSFA, so almost I feel that most of the cases admitted in the ICU, most of the cases follows the criteria of QSFA, but we cannot take it as a sepsis. So, but the overall clinical history and the physical examination.
See, what I think is happening is the country like India, where we have such a huge burden of sepsis patients, and this is not uncommon and very rare to have sepsis and organ failures. In those situations, we need a scoring system which has high sensitivity. We all know ki SIRS criteria, where we are taken leukocyte count, fever, tachycardia, and respiratory rate. If two of them with a suspected infection,
Yes,
need
sir.
to be considered as a sepsis, was too sensitive. We do understand that was too sensitive. Majority of our patients will have fit into that. But probably that is a screening tool to analyze them and rule out and send them back. But the specificity of this SIRS criteria was extremely poor.
Poor, yes, sir.
Whereas the the sensitivity of QSOFA is extremely poor. Probably the mortality prediction with the QSOFA was a better. Now we are talking about curve 65, which we used for community acquired pneumonia admissions. We are also talking about new scoring system, early warning signs, which we used to use for other sicker patients in the ICU to pick up the sicker patients of even sepsis in that category. So that is one area. And we also realized that the sepsis, which we see in Western countries, is completely different from what we see in India.
Yes,
The
sir.
reason is the epidemiology and the microbiology both. The healthcare support and at the public community level, the behavioral changes, the hygiene practices, the clean water availability, the clean air availability, and the population density, all this also plays a role. And being a tropical country, the tropical infections also play a role. For example, now we are seeing a rampage of both dengue and some of the cases where also we are seeing from influenza, H3N2, and some of the COVID also we have seen some cases where they are coming. And because of this monsoon season, we are also seeing an enteric fever as being one of the common. So these are the mix of tropical fevers, which actually adds up to our problem of sepsis in them. So sepsis is not just a bacterial infection or a viral infection, what we see in West, but here we add these all tropical infections in Indian context.
Yes, sir.
So this is where we are all adding to those problems. So coming to the other resource limited settings. So you have been worked in you are postgraduated in a public sectors and also now into a private organization. What do you think what about this, the support of healthcare systems causing differences in care and also the cost burden on the patients, which may be causing a hamper in the sepsis management in many situations?
Yes, sir. So, sir, usually in the resource limited peripheral setups, where actually there is so much of delay in taking the cases, and the actually patients also like whenever they get fever or some kind of fever or some kind of infection, UTI, whatever it is. So actually there is lot of delay is happening, and and they ultimately landed up into the sepsis and septic shock. So whenever they are very, very sick, then they are approaching to the hospital and going to the some higher centers, tertiary centers to pick up that septic shock. So this is what I feel happening in India, especially where there is so much of delay that leads to very high ICU sepsis admissions, and also very high mortality compared to the Western world.
The delay in presentation, what we have realized in the delay in presentation, because of many reasons, maybe the awareness is a challenge, and maybe the primary healthcare facilities referring these cases to a higher center is a challenge. Sometimes the financial constraint is a challenge. So there are multiple things. So these patients reach to the tertiary care in a very late stage relative to what we see in many of the Western countries. So that is also a leading cause for increase in mortality. What we have seen as an experience in last 15, 20 years of my experience in the critical care department, if we receive a patient in the early part of sepsis, even though the patient is in hypertension and early organ dysfunction, there is always a good response. There was a majority of the times it was a good response once you try to give appropriate antimicrobials and resuscitate them with volume. If there is a source control possibility, doing it recovers a good chunk of patients. But if the patient reaches to us late and you are already in a state where you have lost the protoplasm, you lost the time, and point of no return goes up, and your lactates are climbing, your diastolic pressure is bottom low, you are not able to maintain the MAP, no amount of supportive care many of the times saves our patient. So the timing is equally important. Hareesh, there is also always a concern related to the antimicrobial use. So we
Yes.
one side are talking about the availability of them to those who are needy. The other side, we are also talking about there is a rise of antimicrobial resistance because there is a misuse.
Yes.
What do you think? Are we overusing or misusing, and where is the problem? If you are overusing, then why are we having so many deaths?
So definitely in India especially, so the detection rate is very low, sir. So most of the times many of the physicians, like, they use empirically, and the detection rate and detection sensitivity, like when the immediate before starting the antibiotics, actually we should send the blood cultures or any cultures related to that particular site. But there is most of the times what is happening is like many people are starting empirical antibiotics, after that sending culture reports, blood cultures and all, so that the pickup rate also gone down. And because of the over usage of antibiotics, there is lot of resistance is rising. So that is also one of the major issues.
Mnaimala ma'am, thank you for joining back us. Ma'am, please explain us what was your journey, where you started, where we are. Just explain. We all wanted to learn your journey of sepsis management.
Yeah. So the journey of sepsis over the last 30 or 35 years, where I'm seeing in the critical care, is rather the bacteria are taken over, right? Because they have become very resistant, because we have been misusing our antibiotics for a long time. So anybody comes even today, they would have been used already antibiotics from even a small hospital, they have come, or a, even rural area, everybody is using antibiotics. In that way, you cannot really, so we really cannot say, because now the bacteria have been there for millions of years before us. They are much smarter. So they get something or other, they will get they will develop resistance to what we can give. So idea is to spread this more and see that we use less antibiotics. It's all there on paper, but how much are we really able to do? Earlier, when we saw, even Acinetobacter is very rare. E. coli was the commonest organism in the 90s, early 90s, or even in the late 80s. E. coli. Then later on, then slowly we have gone to, by about the mid 90s or this thing, we got Acinetobacter. But Acinetobacter was very easy to control. Even amikacin, it was, fairly, we could give amikacin and get off with that. So most of the drugs were sensitive to this. Then later on, we went to cephalosporins. Then with the cephalosporins, our magnets. Then after that, peptides. Peptides become very, very useless because it was used so much in that. And now we have got meropenem, and all these are also available in the urological area and other areas also as tablet form. The moment these things come as tablet form, then the usage is very, very, very common, even to the high end. We don't have a proper antibiotic control from the central government or the state government. So it becomes very difficult for us when we come into the ICU. Already they have used up at least 1 or 2 major antibiotics. So what is that you can do? You can only use the bigger one.
Yeah, you are saying we lost to microbials over the antimicrobial use. Over a time, we are slowly losing to them. They are becoming resistance, and the use became a challenge. So, ma'am, one side we are talking about there is a lot of use of antibiotics in the community or in the different layers of healthcare system. The other side, we are saying there is an increased mortality with sepsis. So use of if suppose we restrict antimicrobial, the availability of antibiotic will also get limitation. So one side, the usage, we are saying overuse. The other side, we are saying again, there is an increased death of a septic patient because they are not getting antimicrobials in appropriate time or resuscitation at appropriate time. How do you balance, ma'am? In India, I understand your valid point of regulating antimicrobials, but our healthcare system has not strengthened to that extent that we can restrict them to only a tertiary care because good percentage of population cannot reach the tertiary care. So how do you see, ma'am, as a senior mentor in this area?
Well, I think there is more and more thinking about it. And to see, if you get in critical care, you have no other alternative except to use the bigger antibiotic and see that the patient comes out first off the ventilator and other, whatever things. But basically what I feel is, if you can get them faster, so this is, if the sepsis can come, even if you have got a mild shock, say about 100 systolic, and if you have got a tachycardic, and if he is a little bit not eating, not talking with too much in the house or in the hospital, those are the patients who should be treated quickly to the ICU. They should send them to ICU. There used to be a time where I used to go to the emergency medicine, bring patients to the ICU. I say, no, you cannot treat this patient. Of course, people call me dominant, but then that is what is required. I think you have to be constantly in touch with the emergency medicine so that you can bring them faster. That is one. Then get all the people, what is that really they want to see. So I used to tell them, okay, if this is the thing, call. And you have some sort of you have a med team, so they can also go there and see that. So such of these, if you can sort of improve to bring them faster to the ICU. They little late. They bring them late. They'll say, it's okay, not necessary. At least a high-end, about 4 or 5 beds separately for sepsis. Keeps like, your fluid and your NORAD and your vasopressin or your steroid. They're given very correctly along with the antibiotic. Then it is. Because sometimes they wait for the culture. The cultures they don't take. So the sisters have to be trained. It's all a good training. you must have a sort of a trained personnel all through to see whether these things have been done. Because I myself, I remember. So I used to find, okay, 1 hour you have given. Then I did one study, even Yashoda. It was not given. It will be, many times they'll say right there given, but it is given. And who has written that? All those things can be seen as we can do a big study, Ramana, on this in whole of India and get the things.
Ma'am, now I think surviving sepsis guidelines also, even ISCCM is now insisting on performance indicator sepsis, as you rightly pointed out, performance indicator. If you are an institution in a septic patient, you also do a performance indicator, as you rightly said, after patient reaches to the emergency room or to the hospital, by what time you are delivering antimicrobial, by what time you are taking cultures, how do you resuscitate, and what is your mortality rate in them, organ dysfunction. Performance indicators became a mandatory like your other scoring systems, ma'am. And you rightly pointed out, you repeatedly emphasized early picking up. You see a patient who is unwell at home, who is not doing well after the symptomatic medications, needs a early attention. And you also pointed out that early escalation and referral system, a primary care clinician referring to a hospital. So these are, ma'am, antimicrobials are one side. What are the other changes you have seen in this last 35 years in managing sepsis?
See, doctor, I have been involved with the Zyris or the activated protein C. We have done some, like the Prof study was done, and in that they found that single organ patient rare blood, instead that in a, and that was the address study, which we were also part of. And it was a disaster doing it in a single organ. Patient had more bleeding. There is no need. At least you should have 2 organs and it should be done correctly. So if we do those things, other thing, of course, is cytosorb and other things. But these are again, if there is no any renal failures. But of course, another thing which I strongly felt useful was ulinistatin, particularly in pancreatitis. I still use it, and I tell them it will be useful provided you use it early rather than late. So this is, I have seen all these things, but that Septivac, whatever that medicine, even that they have not found it very well. But I suppose you have to do in a larger number of patients. And we know that the mortality is much higher when you have comorbids and when you have, older age group. So is it very greatly justifiable by doing all these things in that sort of a, people who have got diabetes, hypertension, hypothyroid, there's that, all that, plus around above 70 years. Are we justified in comparing them with a younger age group? So we have to separately look at that age group and then see whether they really work. So this is what is my thought. In others, I think we should be able to try.
How tropical fevers in India complicates the issue of sepsis, because we do see malaria, dengue, lepto, enteric fever, all this leading to sepsis and coming to our emergency rooms and ICU and behaving the same way like a bacterial sepsis. And that's a geographical problem of tropical countries like India.
Yeah, for us also, it is a fairly big problem. It is sort of a seasonal. So in the seasonal time, we know that dengue now is, quite common. The main thing with these is early intervention. Did they get the correct drug, the correct dose? That is important. Many times that is not looked into. And how long did they get it? So if these are this thing, but we have seen in some people in dengue, you have a lot of mortality in certain individuals. We can't say who is it. That is our challenge as a doctor. Who is going to succumb? A young fellow who comes maybe a little late, he may succumb. An older fellow who has come on time, he may, you know, he may become better and go. So that is our main problem when we explain to our patients also. Sometimes we have to say. So we have seen a lot of encephalitis, scrub encephalitis, and I've written papers also on this. And what are the clinical spectrum of a dengue patient? So like that, if you can sort of take care of what you are getting in your ICU, and if everybody can put together those things, I think it will make a lot of, and when did we start and how did we start? These are the things I think if you can have a registries like that would be very, very useful to a country like ours. If we can have a registry, Indian registries of our ICUs, and what is the type? Suppose if you say dengue, how many, every ICU should be able to sort of put it on the registry. So that way, I think we should work towards that goal.
So, Dr. Santos, you are asking about the tropical infection, including in the surviving sepsis guideline. I think we, as a country representing, Dr. Yatin Mehta was representing as one of the members in the surviving sepsis campaign. Probably we are talking about the addition of the guidelines for a resource limited setups also, and including the countries like low and middle income countries like India's problems. And ISCCM is coming up with a position statement in sepsis management. And in that, I think we are covering all these tropical infections, and even we have a guidelines for tropical infections, both from API and ISCCM statement in that. So these are our areas problem. So we need to define our areas. So tropical infection will complicate the situations in India. So I think that is a part of our guidelines and we should create. And he asked another question, role of IVIG in necrotizing fasciitis and streptococcal toxic shock syndrome. See, ma'am, any comments on that IVIG role? So we mostly the last a decade before, in a situation where the toxin loading causing the problems in toxic shock syndrome, like either a staphylococcal or a streptococcal toxic shock syndrome, we used to use an aggressive debridement along with the antitoxin agent, something like a clindamycin in a dose of 900 milligram TID to a linezolid in a 600 milligram IVBD. But use of IVIG in those situations to neutralize these toxins were a phenomenon. But over the last decade, the concept of using IVIG to neutralize this toxic shock syndromes has not been proven in the recent studies, and it's no more been used as a standard of therapy. So IVIG in streptococcal toxic shock syndrome is not a regular standard of therapy needed nowadays. As we all understand, the streptococcus are very virulent, even though they look sensitive to many. Ma'am.
Yeah.
So other things are related to, do we are actually expecting any newer innovations in the managing sepsis in the era of antimicrobial resistance? The bacteriophage and there are nanoparticle managements are on trial. I don't know when they will be in reality and will be available for a patient care, but there will be a lot of research and experiment happening in this both. Ma'am, any comments on that?
Yeah, well, there will be always research will be going on. So the ultimate thing nowadays is everything nanoparticles. So I'm sure there will be something which will be coming up. But whatever we have as on today, you should use them at the right time, at that particular time, which is available and what is the best for that particular patient is what we have to decide and then do it to the best of our capacity. The first thing first, so give fluid, give noradrenaline, give vasopressin. If the dose is going, give the steroid. And then you see that you keep up all the, particularly when you intubate, you see that you do not get a VAP. How you can do possible to totally prevent, because already is immunocompromised with all this sepsis. So there is extra things are there. We can isolate them, keep them in this thing. These are the things which we have to constantly see. But then once you isolate, sometimes they don't do the suction. Without suction, they will get into problem. Sometimes they will not change. So the protocol has to be adhered very, very, very meticulous, so that we can reduce the number of
Ma'am,
super added infection, hospital acquired infection.
ma'am, there are
Yeah.
questions related to bundle. So you must have been seen few bundles has been added in the last decade, one after the other, 6 hours bundle, 3 hours bundle, 1 hour bundle. As you rightly pointed out, few of them, taking a blood culture or appropriate culture, using an appropriate antimicrobial, managing the SOC, probably using a marker like lactate or a capillary refill time. So something like that, the bundles, the question is, did these bundles help you over the last few decades? Or is it a point for the primary care clinicians to remind them that these are the basic things they to do?
See, bundle, by the time they come to us, all the bundle has been, at least the first hour bundle is done, right? In the emergency medicine. I think emergency medicine has now developed well. Earlier it was greatly it has developed.
Yes.
And we have developed that first, I was the first president for emergency medicine. So I knew that we have to have a proper area there. So because when I trained myself way back in the 60s, we had a good casualty where we could go and do everything there, even anesthetize patients. So what I am only trying to say is sometimes even, the source control. Suppose if you have got a patient who has got a very bad ulcer, and then it is all, the whole thing is really sloughing, and he has got very low blood pressure. What do you do? Such patient, if while shifting, they can have bradycardia and arrest. So not do it in the, I will get it done with, because get your things and we do it. So that way, even like stent place, we have done unless you do, patient is good. Whatever is second.
So there are questions related to recombinant activated protein C and doxycycline alpha. These, as we discussed,
is done at the earliest. They'll all say, bring up the blood cell, let it come up. Course is not wrong.
So there are questions related to recombinant activated protein C and doxycycline alpha in sepsis. Both of them are not, they are not available right now in the market. And as pointed out by Hareesh in his presentation, initially few studies at that point of time showed some benefit, but later on there was no mortality benefit. So that particular drug was discontinued from that company. So it is no more available. See, everybody, Dr. Mnaimala Rao and Dr. Hareesh tried to point out that there are few areas which we need to emphasize. One is early recognition of patients, of those who got suspected or have a confirmed infection. If they are not well, if they are unwell in his general condition in any form, either like they are lethargic, in altered sensorium, not taking food, or they are in low blood pressure, low urine output, or they are cold and clammy on the peripheries, any of them should alert a clinician to need a more monitored and vigilant care and aggressive resuscitation. That's what we were talking about. And what it means in the early recognition and more monitored care is, whenever you actually suspect a sepsis, quickly actually picking up these cases and trying to send appropriate blood culture and giving an, at least at that point of time, appropriate antimicrobial in that context. And probably monitoring some perfusion ways, like what we said, either a lactate, and nowadays we are also saying a capillary refill and a peripheral perfusion can be as equally good like a lactate. And then probably managing a hypertension by either a volume, maybe few liters of IV fluid if the patient is responding, and a vasopressor if required to manage the blood pressure is the primary thing. Followed by this, multiple organ support may be needed in some situation, and those all need to be done. And then comes source control. If a patient needs a source control, that need to be done in a earliest way possible. And after these all measures, if the patient still remains to be unstable, and we talk about the immune response is the major play, and we have talked about a series of maybe salvage therapies or kind of rescue therapies, that what Dr. Hareesh has mentioned, that you can use some adsorptive filters, high volume filtration, or some kind of a polymyxin based filters, or something like auxiliary filters, which are been used in many of these contexts, even though we do not have a robust literature evidence supporting their benefits in a large randomized trials. But there were pockets of trials which has shown a ubiquitous results, one supporting, one against. So these can be used as a rescue or a kind of a salvage therapies. And coming to the others, the steroids has taken its own pendulum, that initially we spoke about high dose, then we said no benefit. Then now we are talking about a dose which is equivalent to 200 milligrams of hydrocortisone in divided doses in 24 hours. If a patient on a vasopressors not maintaining the map of 65 or 70, probably you are using this hydrocortisone. And coming to those the metabolic resuscitation, which Dr. Hareesh mentioned, that there was a lot of interest in use of vitamin C, thiamine, and hydrocortisone, and these been used as a resuscitation measures, has not proven to be successful when they have been studied in a proper randomized trials in a larger population. So ascorbic acid in particularly in that doses has no more recommended, and surviving sepsis guidelines gives guidances against use of it. And probably the thiamine role as a supplementation of micronutrients and vitamins can be used, because many of our population may have a deficit on thiamine, but its role in that form of high dose may not be required. And the other all experimental things which we mentioned, like role of statins, ulinastatin, or those which I'm talking about are bacteriophage, nanoparticles, and immunomodulators, all has its limitation at this point of time, and they've not been well studied in at least bacterial sepsis. But if I talk about a sepsis condition with a COVID-19, we have seen some IL-6 inhibitors has some role to play, but that is again a very separate group of population with a separate clinical syndromes, where we say cytokine storm with a defined way, and that is a separate subgroup of septic patients. And in dengue, again, we have seen few of the patients land into the same kind of cytokine storm and landed into multi-organ failure and dialysis and death. So this is a kind of such a wide spectrum, where probably one case cannot be compared with another case. This is the challenge which we are facing across. So on the occasion of World Sepsis Day, I probably thank all of you to participate in this webinar and probably giving us an opportunity to present this. I thank Dr. Hareesh. I thank also Dr. Mnaimala ma'am to be a part of this session and given us this horizon of sepsis awareness. And I conclude the session. Thank you, Hareesh.
Thank you, sir.